Good evening and thank you for joining me in continuing the antileprotic drugs. So in the first class I had mentioned about the classification. I had just briefly introduced you towards the types of leprosy we can notice and what is the difference between both. And I had just started with the first drug, that is the dapsone, which comes under the sulfone group. Now moving over to the second drug is clofazimine. So it belongs to the phenazine derivative. It is a dye, it is leprostatic, and also it possesses anti-inflammatory properties, and it carries out its action by interfering with the template function of the DNA in Mycobacterium leprae. And when this particular drug is used alone, resistance develops within 1 to 3 years. So it is not advised to use it alone. Alright, so it has been included under multi-drug therapy. And also, dapsone resistant Mycobacterium leprae respond very well once this particular drug has been started. If you check out the pharmacokinetics, it is orally active. 40 to 70% gets absorbed. It gets accumulated in the tissues, especially in the fat, in the crystalline form. And entry to CSF is very, very poor. The half-life is 70 days, and because of that, we can use this particular drug as an option for intermittent therapy. Now, availability of this particular drug. You can find this drug under the brand names like clofazine, Hansapron, like 50 mg or 100 mg capsules. And it is used under multi-drug therapy in treating leprosy as well as in treating Mycobacterium avium complex. Okay, so we can say it has got a use in as an anti-tubercular drug too, and that too it is occasional. Now, adverse effects. So adverse effects can be minimized if we incorporate this particular drug under multi-drug therapy. But still, we need to know what are the effects you can notice. Coming over to the skin, you can find that it turns out to be reddish, black discoloration of the skin can be noticed. You can notice dry skin, itching will be there, acne form will be there, photosensitivity will be there, and you can find discoloration of the hair and body secretions. And reddish black discoloration you can find only on the exposed part, and conjunctival pigmentation can also be noticed. Moving over to the gastrointestinal tract. In gastrointestinal system, you can find enteritis with intermittent loose stools, anorexia, abdominal pain, nausea, weight loss. It can occur, particularly when high doses are given to control lepra reaction. In the first class, I had mentioned briefly about lepra reaction that you can expect during the treatment of leprosy patients. Okay, once the treatment has been started. Okay, usually it happens due to the dapsone treatment. Alright, so once the lepra reaction has begun, to control that, we go for giving this particular drug. So the early syndrome is usually due to the irritant effect, okay, which can be reduced or which could be subsided by doing a dose adjustment and also by taking the drug with meals. A late syndrome will be happening once few months get completed after the therapy, and it's mainly because of the clofazimine crystals getting accumulated in the intestinal submucosa. And contraindication: early pregnancy and those patients who are diagnosed with liver or kidney problems. Okay, such patients should be avoided from here. The third group, anti-tubercular drugs in leprosy treatment. We have two drugs, rifampin and ethionamide. So compared to ethionamide, we use rifampin more. Okay, and ethionamide, its usage has been limited mainly because of the high cases of hepatotoxicity. So let's see about rifampin. So it is antitubercular and it is bactericidal to Mycobacterium leprae, and it renders the leprosy patients to become non-contagious. And 99.9% of the Mycobacterium leprae gets killed within 3 to 7 days. But it should not be used alone. Like I said, to avoid the development of resistance, it has to be incorporated under multi-drug therapy. And it has to be given at a dosage of 600 milligrams, and that too monthly dose. And it has found to be non-toxic, and also it does not induce the metabolism of other drugs. Contraindication: patients with hepatic or renal dysfunction. The rifampin congener, if you have gone through my antitubercular drug, there is a rifampin congener called as a rifabutin. This is also bactericidal in nature against Mycobacterium leprae, but it's if you compare the scale of the result that has been produced, the rifampin stands high when compared to the rifabutin. Ethionamide, antitubercular drug, very good antileprotic activity, but hepatotoxicity has caused its limited usage, and that too its usage becomes necessary only in the areas where it has to be used, and it is being used as an alternative to clofazimine, but other substitutes are being preferred, and the dosage is 250 mg per day, and like I mentioned, where it has to be used only in that particular area, we can go for using that particular drug. Moving over to the antibiotics. Now, antibiotics, we have incorporated macrolides, we have incorporated tetracyclines, okay, but ciprofloxacin does not carry out a very good role in it. So apart from ciprofloxacin, we have incorporated drugs like ofloxacin, minocycline, clarithromycin into these particular drugs. So let's have a glance about ofloxacin. So ofloxacin, it has been added as a component under multi-drug therapy, and it has found to hasten the bacteriological as well as a clinical response of this particular drug. And 99.9% of the bacilli gets killed by just administering 22 daily doses of this particular drug. And it's not included under standard treatment regimen, but it can be used under alternate regimens where the rifampin cannot be used, and also to shorten the duration of the treatment. The dosage we go for administering is 400 milligrams per day. Next drug, minocycline. So I want you to remember minocycline. Whenever we hear the word cycline, if any drug ends with cycline, so remember it is tetracycline. So this is a tetracycline. Due to its high lipophilicity towards it gets attached to the lepro, or its activity is very high against the Mycobacterium leprae. A dose of 100 mg per day produces peak blood levels that exceeds minimum inhibitory concentration against Mycobacterium leprae by 10 to 20 times. Its antibacterial activity is much less when compared to rifampin, but greater than that of clarithromycin. And 100 milligrams daily monotherapy, it will render the patients of lepromatous leprosy negative within 8 weeks, and it has been considered as an alternative in multi-drug treatment regimen. Clarithromycin, it's a macrolide antibiotic, very good activity against Mycobacterium leprae, and however it is less bactericidal when compared to rifampin, Monotherapy with clarithromycin 500 milligrams daily has caused 99.9% bacterial killing in 8 weeks. And due to this, it has been included as an alternative in multi-drug therapy. So with this, I have completed the antileprotic drugs. Now I also want you to remember about reactions, like when we were discussing about the dapsone treatment. If you just view my first class of antileprotic drugs, you can find that I had mentioned about 2 reactions that you can notice. One is lepra reaction, which usually starts because of the dapsone treatment. Then we have is a sulfone syndrome, again due to the same particular drug. One more particular reaction which we have to expect is reversal reaction. Reversal reaction, you can find that in tuberculoid leprosy, and it is a manifestation of delayed hypersensitivity to Mycobacterium leprae. Delayed hypersensitivity to Mycobacterium leprae. Because of that, this particular reaction starts. Now if you see what are the signs of it, it is cutaneous ulceration, multiple nerve involvement with pain and tenderness occurs suddenly even after completion of therapy. So I want you to remember, it is after the completion of therapy. It's not during the therapy. Lepra reaction and all, we can find it once the therapy has been started. Alright, and sulfone syndrome is after the dapsone treatment, a completion of 4 to 6 weeks. But here the therapy has been completed. It's not just only dapsone, the entire therapy. And here, how do we go for treating it? It is the administration of clofazimine or corticosteroids. It has to be administered over here. Now, I just want to give you a small glance about multi-drug therapy of leprosy, which we administer for multibacillary leprosy and paucibacillary leprosy. Multibacillary leprosy is said to be contagious when compared to paucibacillary leprosy. You can just check my first class video of antileprotic, where I have cited the differences between both, and in that I have mentioned which is the infectious and which is said to be the non-infectious stage. In multibacillary, rifampin will be given 600 milligram dosage once in a month, and it is completely under supervision. In case of paucibacillary, it is the same dosage, 600 milligrams once a month supervised. Dapsone, in case of multibacillary, we go for administering it at a dosage of 100 milligrams, and it is self-administered daily, whereas in paucibacillary it is 100 milligrams daily self-administered. Clofazimine, in case of multibacillary, 300 milligrams once a month supervised, and after that 50 milligrams daily self-administered, and this will not be given in case of paucibacillary. And I want you to understand this multi-drug therapy varies in duration for multibacillary as well as this multi-drug therapy varies in duration once it comes for multibacillary leprosy and paucibacillary. So the duration for multibacillary leprosy is 12 months, whereas in case of paucibacillary it is 6 months. Okay, so this is usually the multi-drug therapy which is being given for both multibacillary as well as paucibacillary. Okay, so the advantages why we go for it is, the advantages: effective in cases where primary dapsone resistance has been noticed. It prevents any emergence of dapsone resistance. And third one is, it reduces the total duration of therapy. So mainly because of this multi-drug therapy has been found. Nurse's responsibility. So initially they have to be supervised. You have to categorize them by doing this lepromin test and skin test and find out under which category they belong to. Followed by that, you have to carry out certain baseline investigations like their blood levels, their kidney function test, their liver function test, and a complete head to foot examination should be carried out. They should be assessed very well about their health status, and based on that you need to identify which are the drugs which is safe for them, which can be administered to them. And a continuous supervision should be done, and the patient has to be educated, because there will be certain discoloration of the skin, secretions, and there will be a lot of adverse effects, and even the reactions which we can expect during this antileprotic drug therapy. Those also should be expected, and that should be supervised, and the patient has to be notified about it, and the treatment should be started. So these are some of the nursing responsibilities that you need to carry out. So I hope you have understood my class on antileprotic drugs. I hope you have enjoyed it, and take care. Bye-bye.